Okay. Hi, everyone. Thank you so much for being here. We're going to get started in a minute or two. We're just waiting for people to join. Hi, everyone. We're going to get started in maybe half a minute. We're just still giving people time to get onto the webinar. Okay, it looks like most of the initial joiners have joined. So good afternoon. I'm Jonathan Lynch with CDC's Division of Environmental Health Science and Practice, and thank you so much for coming today. A few quick housekeeping notes. All participants joining us today are in listen-only mode. Closed captions are available for this webinar. Next slide, please. Today's Nexus webinar will be available to view on demand in a few days. You can find the video recording of today's webinar at the CDC Nexus webpage at www.cdc.gov/EH-Nexus, Nexus. Or you can scan the QR code, and also I'll post a link in the chat. Next slide. You may submit questions at any time during today's presentation. To ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question in the Q&A box. We often get more questions than we have time to answer. So if you have a follow-up question, please email us at ehnexus@cdc.gov. If you're a member of the media and you have a question, please contact CDC Media Relations at media@cdc.gov or call 404-639-3286. Next slide. So please note, the findings and conclusions in this report are those of the authors and do not necessarily represent the official position of CDC. Next slide, please. These are today's speakers. We have 5 speakers, and next slide, please. These are today's presenters. We have 5 presenters as well. And next slide, please. And to get us started, here is CDC's Director, Mandy Cohen.
Hi, everyone. I'm Dr. Mandy Cohen, Director of CDC, and I'm glad to be here to discuss how we can better protect communities from the impacts of extreme heat. Heat is a threat to our health. It can make underlying health conditions worse, and heat-related illness like heat exhaustion and heat stroke can cause serious illness and even lead to death. Heat can be especially dangerous for certain people, including our very young kids, kids with asthma, older adults, pregnant moms, and people with underlying health conditions like heart disease. 2023 was the hottest year on record, and we know that heat waves are continuing to intensify, to last longer, to span larger areas, and are putting the lives and well-being of many at risk. While anyone can be impacted by heat, some people and communities are disproportionately impacted. Working with communities will maximize health benefits and help to build heat-resilient communities. Protecting health and improving lives is a team sport. I'm so grateful that so many of our teammates are here today so we can discuss actionable strategies to make a difference. We have more tools, more data, more information than ever before. And more importantly, we have all of you. One of our 2024 priorities at CDC is readiness and response to health threats, including addressing extreme heat. At CDC, we're bringing our response readiness, expertise, and investments to protect health and improve lives from the impact of heat. To be prepared for the summer heat, CDC has developed a new dashboard that includes the National Weather Service Heat Risk Map and the EPA Air Now Air Quality Index. This dashboard, which you can access at cdc.gov/heatrisk, gives you real-time heat risk in your area and advice on how to protect your health. You can put in your zip code and you can see current heat risk and air quality levels and a 7-day heat risk forecast for your area. So you can plan your day and your week with your health in mind. As we get ready for hotter temperatures this summer, here are a few simple actions for all of us to keep in mind. First, stay cool. Plan around high heat risk days. Find indoor locations to stay cool. Schedule outdoor activities for the cooler parts of the day. Second, stay hydrated. Drink fluids and replace salts you lose when you sweat. And drink water regularly throughout the day. Third, stay informed. Use CDC's Heat Health Dashboard to check the risk levels in your community as you plan. Because children with asthma, pregnant moms, and people with heart disease are particularly at risk, CDC has new guidance for clinicians and patients about how to prepare for the hot months ahead. Our new guidance has condition-specific heat action plans to help your patients stay well when it's hot. We're asking clinicians to talk to their patients and families about how to stay well in the coming months. So in closing, as we prepare for the hot summer months ahead, we know heat can impact our health, but heat-related illness and death are preventable. During today's webinar, listen to the experts discuss strategies and resources to keep your family healthy and safe from the heat in the coming months. Thank you, and stay healthy. Hi, everyone.
And now we have Dr. Ayanna Perkins, our Chief Health Equity Officer. Ayanna.
Thanks for that introduction. Hi, everyone. It's great to be here with you today. Before I begin, let me describe myself to those who are not able to see the video image. I am an African-American woman with long locks wearing a white jacket. My pronouns are she and her. And just to let you know a little bit about me, when I think of summer, I think of the hot days when I sold ice cream in college in front of the National Air and Space Museum. In my presentation today, I will briefly highlight how supporting heat resilience is a health equity issue in our division. Next slide. Here in our Division of Environmental Health Science and Practice, we address exposures to extreme heat and other environmental health hazards. Next slide. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. In our division, we approach health equity in 3 ways. We explore social determinants of health, environmental justice, and diversity and inclusion principles in each of our 8 strategies. Next slide. Our work is aligned with CDC's core commitment to health equity. We optimize our heat-related tools and surveillance systems to address place-based and systemic factors that may be preventing access to the vital conditions we need. Next slide. Our division uses the 7 vital conditions for health and well-being framework to guide our health equity work. Vital conditions are properties of places and institutions that we all need to reach our full potential. The Federal Plan for Equitable Long-Term Recovery and Resilience, which we support, also draws on this framework and promotes freedom from extreme heat for everyone. These 7 domains are community identified, interdependent, and encourage a whole of government approach. Very often we focus on that one domain for heat in purple, right? Our direct exposure in our natural world. But exploring how we thrive in our natural world is not the only domain to consider. When planning for heat resilience, we must ask, do all communities have access to the other domains, such as their basic needs for health and safety? Do we all have humane housing, meaningful work and wealth, an opportunity for lifelong learning, reliable transportation? And right there in the middle is the most important part. How do we draw on belonging and civic muscles, this strong resource in our communities? Next slide. When planning for heat resilience, we must all respond appropriately to social, historical, and spatial contexts. We need to know how to plan for safer conditions for workers who spend a lot of time outside, collaborate with our healthcare providers to assist their patients against extreme heat, help others obtain housing with effective and affordable cooling options, assist all communities in gaining a living wage so they can afford to implement heat protection strategies, develop tools that assist with planning for extreme heat events, and increase access to affordable and safe transportation so we can access cooling centers and our other basic needs. And also in the middle, before we roll out any intervention, we need to engage our communities to determine if these heat resilient strategies are culturally and contextually appropriate and effective. All of our presenters following me offer examples of social determinants of health that influence heat resilience. Next slide. Communities that have been minoritized and have been historically denied resources are disproportionately impacted by extreme heat, which makes this an environmental justice issue. We can all revitalize our commitment to environmental justice by becoming familiar with the recommendations from Executive Order 14096. Please be on the lookout for groundbreaking summer release of a federal environmental justice research plan that responds to this executive order. Next slide. If you want to learn more about how we're addressing health equity and environmental justice in our division, email me. I want to give a special thanks to Desiree Robinson of the Office of Health Equity and Claudia Brown from our Division Climate and Health Equity team, who were a huge part of organizing this effort. I want to thank you for your attention. And next up, maybe two folks, our Chief Medical Officer and our Chief of Climate and Health Equity, Paul Schramm. Turning it over to you.
All right, good afternoon and good morning, everyone. So I want to thank you for your interest in sharing some time on your busy day with us. So I'm Arthur Chang. I'm the Chief Medical Officer of the Division of Environmental Health Science and Practice here at the National Center for Environmental Health, CDC. I'm a medical toxicologist and emergency medicine physician by training. From my experience of practicing in an emergency department, I have seen the detrimental effects that social and economic inequities have on people's health. Our division here at CDC works on several environmental health issues that affect certain groups of people more than others. Illnesses like asthma, environmental exposures like lead, radiation in the form of radon, and drinking water contamination. We also do a lot of work on natural disasters like hurricanes, wildfires, and extreme heat waves. Health equity is a key part for all these topics, and we focus many of our efforts on communicating to disproportionately affected groups and on identifying practical interventions that work best for them. And of course, heat is one of these environmental health factors that has a big health equity component, particularly for those who are more vulnerable. I think it's very important that all of us, public health professionals, emergency managers, and clinicians all work together. With that, I don't want to take any more time, and I'll pass it on to Paul Schramm from our Climate and Heat program. Thank you.
All right, thank you, Dr. Chang. And hi, everyone. I'm Paul Schramm. I'm the chief of the Climate and Health Program at CDC. Back in 2019, here in Atlanta, where I live and where CDC is located, a high school was holding outdoor drills for the basketball team. That day, the temperature was 97 degrees with a heat index over 100 degrees. A 16-year-old girl started feeling lightheaded during the drills. She collapsed, and unfortunately, she died of heat stroke. Heat is something that's already affecting our communities and our health, and the threat is growing. However, these deaths are preventable, and at CDC, we are studying the health effects of heat and developing tools that can help save lives. Next slide. We see that the threat is growing. As you heard from Dr. Cohen, 2023 was the hottest year on record, with July being the hottest month ever on record. And we're already setting new records in 2024. Globally, last month was the hottest May we've ever had. Next slide. So heat wave intensity, frequency, and duration are all increasing during the climate change, and this poses significant risks to human health. Our data at CDC show that extreme heat in the US causes an average of over 67,000 emergency departments each year and over 1,200 deaths. And we know that these are underestimates because heat is not always properly coded in death certificates, for example. Next slide. And while we know that heat can affect anyone, there are disproportionate impacts on certain people and populations. This list is just some of the people that are disproportionately impacted, including children, older adults over age 65, some people with disabilities, pregnant people, some people with mental health or substance use disorders, and people without access to cooling or who engage in outdoor labor or other outdoor activities. Again, this is not a complete list, but our data does show these are some of the people and populations that are most impacted by heat. We also see that some BIPOC communities, as well as areas that have been historically redlined or that have urban heat islands, are disproportionately exposed to heat and are in hotter environments. This also includes people that are experiencing homelessness. Next slide. So heat not only harms physical health, it can also harm mental health. And we also see that people on certain medications may have increased heat-related risks. Another thing is that we know that heat waves and exposure to heat doesn't happen in a vacuum. Warmer temperatures contribute to air pollution, so people can be exposed to high heat and bad air pollution at the same time. We also see cases where there may be a wildfire and a heat wave at the same time. So real-time monitoring of these weather conditions and real-time monitoring of the health outcomes can guide the timing of risk communication and other local public health actions to prevent these heat-related harms. Next slide. So now I'm going to talk about 4 tools that CDC has, several of which have been released within the last month and a half, and one released just last week that can help with these local planning processes. Next slide. The CDC Heat and Health Tracker is a free, publicly available online tool to help emergency and public health planners prepare for and respond to extreme heat events. The Heat and Health Tracker brings together data from across federal agencies to provide timely, user-friendly, local-level heat and health information that can inform decisions and public health actions. It can also help to describe at-risk populations and determine resources and potential needs. It includes current, historical, and future projected temperatures, heat-related health effects, and population and community characteristics. Users can also search for information by county or zip code. You'll see in the top right, there's a search for location here bar. You can put in your county or zip code there, create custom maps, view data snapshots, download the data, and access guidance and resources from across the federal government. Next slide. We also have the Heat and Health Index, which was just released. This is the first nationwide tool to combine zip code level data on heat-related illness, pre-existing health conditions and social demographic factors, and natural and built environment factors to identify communities where people are most likely to feel the harmful effects of extreme heat on their health. So this delivers a single ranking for each zip code, and it helps public health officials, city planners, policymakers, and community members pinpoint areas that are most likely to experience these negative health outcomes. So you can access this and explore its capabilities within the heat and health tracker that I just showed. So this is already being incorporated into that tracker as well as on heat.gov. It can be accessed via a tab on the left side of the heat and health tracker. And where I mentioned that you can put in your zip code, it will now pull up this heat and health tracker information. This was a broadly collaborative effort through the Agency for Toxic Substances and Disease Registries Geospatial Research Analysis and Services Program, or GRASP, CDC's Climate and Health Program and Environmental Public Health Tracking Program, and the HHS Office of Climate Change and Health Equity. Next slide. I also want to talk about the heat risk dashboard. This is another new tool and another collaborative effort, in this case between CDC and the National Weather Service. This heat risk is a health-based heat forecast that integrates health and temperature data to deliver a 7-day outlook for hot weather. It uses a 5-level color-coded scale to indicate how risky the heat level is in a specific area. So you can access this via our dashboard on CDC's website that's shown here. You can also access it on heat.gov and from the National Weather Service. This dashboard on CDC's website also includes air pollution data. So we're pulling in air quality information from EPA. As I mentioned before, sometimes there's heat and air quality problems at the same time. You can look at both of those on this dashboard. Next slide. Finally, I want to share heat guidance for clinicians that CDC recently launched. So this series of resources that you see the webpage here includes information on patient management, on heat and medication, as well as clinical guidance for working with patients with asthma, cardiovascular disease, or pregnant patients. Next slide. So these are just some of the tools that CDC and our partners have on heat. We'll place some additional resources from the National Institute for Occupational Safety and Health, or NIOSH, in the chat. We encourage you to also check out the resources on heat.gov, as well as the Low-Income Home Energy Assistance Program, or LIHEAP, which can help with home energy costs, including paying for air conditioning. We hope that these new CDC tools and guidance will empower local decision makers and public health professionals to prepare for and respond to heat, to protect lives, and to prevent what happened to the young high school basketball player here in Atlanta from happening to others. Thank you. And now I'll turn it over to our next speaker, Dave Hondula.
Thank you so much, Paul, and good morning, everyone. Such an honor to be with you all and share some perspectives from the city of Phoenix. It's warm here already as we sit on June 6th. We're in our first formally heat-warned period of the summer with temperatures over 110 for a few days. And I'm really proud to share that I feel like our city and region are more prepared than ever for the hazard we've been talking about this morning. And I'll share a few highlights here over the next few slides. If we could advance to the next one, please. The city, for the third consecutive year, has revised its comprehensive heat response plan. You can see the mission of the plan here on the slide, and this is a plan that is health-focused and engages every relevant city department. Also speaks to engagement with some of our other tremendous partners in the region at the county health department, state health department, our regional planning organization, the National Weather Service, and so many more. Next slide, please. I won't go into all the details of the plan as we don't have time for that today, but the plan contains more than 35 specific actions divided into these 9 strategic areas where the city can play a leadership role or play a collaborative role. And you can see that the themes address some of the topics we've discussed already today, including occupational safety and cool and safe recreation. Next slide, please. We are trying to be as data-driven as we can in our efforts. We look closely at data sets like those we've talked about already. And here in Maricopa County, we are seeing real challenges related to heat in terms of fatalities. We have an excellent heat health surveillance program at the Maricopa County Department of Public Health that unfortunately has revealed many heat decedents in recent years, roughly a 10-fold increase in our number of heat-related deaths over the past decade, a pattern that our elected leaders and certainly city staff are really focused on reversing and changing this pattern. Next slide, please. Again, in our effort to be data-driven, as the animations come in, and here I know everyone doesn't know the Phoenix context and geography specifically, but just to give you a flavor of the types of data we have access to and are thinking about, we're looking very spatially at our illness and fatality cases to optimize where resources are going. And from last summer, we saw some very clear patterns in the data that were largely similar to what we saw in previous years. Unfortunately, we just had more cases. Men older, but not the oldest age groups, both in terms of rates and counts. A very high percentage of our cases have an outdoor place of injury. About half of our heat-related fatalities are among members of the unsheltered community. And of those, about 90% of the cases are substance use related. And I don't offer those as any type of disclaimer or discount by any means. Instead, I offer those as data points that tell us what our programs need to look like if we're going to be successful in moving those numbers in the other direction. We saw the vital conditions framework before, and I think when we think about the circumstances associated with homelessness and substance use, we see immediate opportunities to tie into other parts of the framework, and that's what we're trying to do in some of our measures this year. Next slide, please. To give a little bit of the local context, and there'll be two chunks of text that will come in on this slide. We have a regional network of cooling centers, hydration stations, and respite centers, which allow for more prolonged rest that our regional planning organization started nearly 2 decades ago in response to a severe heat wave that summer that produced tens of fatalities. And you can see how the numbers have changed so much over the past 2 decades. And the city's been a really big part of this effort. We contribute more than 60 facilities as cooling centers or hydration stations. We provide grants to community partners who are part of that effort. And we are the regional, somewhat of the central part of the supply chain to getting signs and water bottles out to heat relief network sites. And I know there are different perspectives and attitudes out there about cooling centers, different ideas, different data. Are cooling centers used? Are they effective? And we in our region absolutely see a lot of use of these facilities. And we have strongly suspected for a long time that they have really positive impact. And this year we've leaned heavily into evaluation of our new efforts to be able to tell that story more concretely. Next slide, please. A pattern that we've observed, thanks, and one more bullet will come in here, is that heat illness cases occur, 911 calls are responded to at times of day when historically our cooling centers have not been open. Ours as a city, and indeed all of those in a region, the heat relief network here has largely been voluntary from an opt-in perspective, which has been great to welcome many partners in who have different types of capabilities, but also has led to the possibility that the system is not necessarily optimized to meet the public health challenge at hand. And here's one way that it's not optimized. At 5 o'clock, 6 o'clock, buildings are closing and people have to go back out into the heat who had been enjoying cooling centers previously. And at the city, our cooling centers, almost all of them were closed on Sundays. And of course, Sundays just as hot as any other day of the week. With the big increase in cases we saw last year and increased awareness of this challenge, we are taking steps as we go to the next slide to solve this problem this summer. We are opening overnight respite and navigation centers at 2 locations. The map doesn't matter so much other than I'll draw your attention to the fact that hopefully you agree that the stars on the map, which are the locations, are near the hot spots of where we have 911 calls related to heat. That's the density map in the background. We've been operational for more than a month already, and tying back to that vital conditions framework we heard about, we have specially trained staff at these facilities who are not only there to welcome you in and help you cool down. That's mission number 1, is to be a heat relief site. But we want to solve the upstream challenges that are bringing people to the heat relief sites in the first place, or other challenges they might be encountering that are increasing their risk related to substance use, related to housing vouchers, whatever it might be. We are trying to work collaboratively with many partners to solve those issues. And we see these locations as a great touch point and hub of resources to be able to do that. And as we go forward to one more slide, I'll just show that we have extended the operating hours at cooling centers as well. These are library locations, adding that availability on Sunday. Same model with dedicated navigation staff, dedicated security at these locations as well, augmenting the great work of city staff and in some cases, volunteers. And as we move to the next slide, which is second to the last, I believe, we have tremendously shifted our internal coordination of these efforts in recent years, where now we are harnessing the full capabilities of our emergency management office and the fire department, adopting an incident management team structure to the heat relief mission. So we have dedicated resource groups, planning meetings. It is a big planning enterprise to make all of this go. We are in daily communication so we can solve the wide range of challenges that emerge with such a complex operational mission. And as we wrap up on the next slide, just wanted to share a couple of highlights about this positive impact that we're seeing already. These data points are a couple weeks old now, but the patterns have held true. More than 70 visits a day across these 5 sites. We're up to more than 4,000 total visits in a month of operation just at those 5 sites as I was looking at the data from this morning. And we are reaching those high-risk groups. We're seeing people experiencing homelessness come to these locations. We're seeing people self-report substance use when they come into the facilities, not at the facilities, but they say that they have used in the past 24 hours, which shows us that we're reaching that high-risk population. People are finding out about them by word of mouth and some new signage the city's created. They're walking and biking there, which confirms the logic that we had in where we would site these locations in the first place. People are being placed in shelters, placed in homes, getting job interviews, enrolling in programs as a result of their engagement at these facilities. We know there's a lot of work to do and a long summer ahead, but we're really, really encouraged by what we're seeing thus far. And with that, I will wrap up and thank you all for being here. And we are so appreciative of all of the work happening in communities across the country. We're eager to learn from everyone and stay in conversation, and hope everyone stays cool and safe. Thank you very much. And with that, I will pass the baton off probably to Jeff Hall.
Okay, forgive me, everyone. We had a little bit of a change with respect to the schedule. I am actually supposed to occur just a little bit later in the presentation today, but in the interest of time, I'm going to go ahead and adapt, as we say, and roll with the punches so that we can stay on schedule. And I hope that this particular pivot will be okay with you guys. So I'll follow Ayana's suit in terms of honoring our colleagues with visual limitations by providing a brief visual introduction. My name is Jeff Hall. I am the current acting deputy director of CDC's Office of Health Equity. I am a Black or African-American male with shoulder length locks, or dreadlocks as they're sometimes referred to. And I'm currently wearing a gray suit with a purple shirt as well as glasses. All right. So now to the meat of the presentation, or the meat of my remarks. Howard Hall Sr. was an amazing man. He had a head brimming with social intelligence, hands deeply calloused via a lifetime of planning and building, a ginormous heart that was our family's driving force. He communed with the outdoors most of his life, be it whispering to the land as a sharecropper, crafting homes from his trees as a carpenter, or traversing it with coon hounds while hunting. Granddaddy and he knew each other well. He was accustomed to it being both friend and foe, given the nature of his work and background. This familiarity, sadly, aided in his downfall. On a 97-degree July day in 1993, he lost his life to a heart attack while cutting grass midday. The heart of gold that set the pulse of my family suddenly stopped. I hate to admit this, but before now, I never gave much thought to Heat's role in Granddaddy's death. He passed when I was 19. I was so consumed by learning that this man, whom I'd never, ever seen ill, had heart disease, that I think I tuned everything else out. The revelation came not from his lips, but from the vial of nitroglycerin in his hand when my uncle found him. For 19-year-old me, granddaddy's killer, heart disease, a villain who continues to strike our family, first emerged here. 49-year-old me now realizes heat was always a co-conspirator. Heat was an instigator granddaddy took too lightly. He labored in the sun and hot longer than I've currently been alive, in jobs spanning agriculture and construction, while tending his massive garden refuge in Birmingham, grown after our family was forced to move there from Old Town, Alabama, driven from land and assets we'd owned for decades. The very hardiness that made him a wonderful provider led him to dismiss risk for harm, heightened when facing heat and health related complications of heart disease. Sharing my granddaddy's story is my way of ensuring our reflections on heat and health equity in community context are made personal, given faces, and tied to social as well as statistical lives. Howard Hall Sr. was the essential worker that thrived despite the agricultural exceptionalism and systemic racism that you'll hear about in one of the presentations to come. His loss makes palpable toxic ties among heat and chronic disease that must be severed. Lastly, Granddaddy's story shows how mindsets and behaviors that increase risk for heat-related illness are often shaped by occupational subcultures. Linking the structural and social with the statistical is key to bridge gaps in empathic concern and in normative distances, blocking progress towards equitable policies that can mitigate heat's adverse effects on historically marginalized and minoritized communities. Such links may help achieve perspective shifts vital to enact policies, processes, and procedures that can eliminate structural inequities driving heat-related disparities. Your presence in this webinar signals your investment in advancing health equity through improving the conditions and social positions of communities disproportionately affected by extreme heat. We appreciate your engagement as we've aimed to stimulate your heads and heart with the content of this webinar. Creating a world where all have fair and just opportunities to become optimally healthy is possible. But doing so, in part, requires address of facets of heat, risk, and resilience, inequitably varying heat-related burdens at the intersections of social statuses like those to be highlighted by our esteemed presenters. We invite you to add heads to your already activated or soon to be activated heads and hearts. We hope you will join us in matching our prevention aspirations with people-focused, community-centered upstream action. Thank you for the opportunity to present to you briefly today. I believe now I'll pass the podium to Jeremy.
Jeremy, yes. Thank you, Jeremy.
Thank you, Jeffrey, and thank you, Jonathan. Good afternoon, everyone, or depending on the time zone or where you're at. I think that after Jeffrey's remarks, this part of the presentation is going to be particularly relevant after hearing that lived experience. I'm the Director of Climate Justice and Impact at Groundwork USA. We're an affiliated network of 21 place-based and people-centered environmental justice organizations in cities all over the country. And so I'll come back to that a little bit later and share a little bit more about what our network does. But we'll start with hotter, wetter, sneezier, and wheezier. So you can go to the next slide, please. As we all know, climate change is brought on by humans intensifying our planet's natural heat trapping gas effect through putting unnatural amounts of heat trapping gases into the air at an extremely rapid rate. And the latest IPCC climate report doesn't pull a scientific punch when it says in its summary for policymakers that it is unequivocal that human influences warm the atmosphere, ocean, and land. Current global climate policies estimate somewhere around 2 to 3 degrees Celsius, or about 3.5 to 5.5 degrees Fahrenheit of total climate warming by 2100. But there is still time, and in my opinion, hope to further limit the amount of total global warming we experience. But that is almost entirely controlled by how quickly we reduce heat trapping gas emissions to net zero. Next slide, please. I was honored to be a lead author for the Southeast chapter of the 5th National Climate Assessment. And in many ways, our conclusions mirror the title of my presentation: hotter, wetter, sneezier, and wheezier. Those are the climate impacts we're experiencing now and that are expected to continue to further intensify depending on how much global warming we allow. Most relevant to the discussion today, next slide, is that under current policies, a person born this decade, like my niece Riley, who turns 3 later this month, could experience as many as 4 times as many heat waves as a person entering retirement this decade experienced during their lifetime. So we're talking about intragenerational injustice here. Meanwhile, next slide, please. Cities are growing, especially across the South and across the West. However, because of restrictive housing policy that limits the amount of housing that can be built to accommodate new residents within places people want to live, a lot of the growth of these cities is actually happening on the exurban fringe in a sprawling automobile-centric design that tends to increase household heat trapping gas emissions. Next slide, please. Sprawling cities also change natural landscapes into paved over and clear-cut human landscapes. Researchers have established for many decades that the way that we plan our cities and design our towns can have a huge impact on their temperature. Wide roads and short buildings, all made out of dense and dark materials, tends to raise the thermostat in a particular place, while tall buildings that cast shade alongside healthy and mature tree canopy with water features and parks, that tends to lower the temperature. These effects are largely independent of, but additive to, climate change. And so that puts this discussion today into an important perspective. If particular neighborhoods within a city have inadequate amounts of nature and trees, are already hotter during the heat waves today, and then you additively affect climate change to have longer and stronger heat seasons due to heat trapping gas emissions, that further underscores the importance of building resilience to heat now. Next slide. But as we've unfortunately learned over and over again, the same neighborhoods and residents in our cities tend to suffer more during extreme heat waves. For example, 1995, city of Chicago, elevated rates of heat-related mortality in historically Black, elderly, industrial, and institutionally marginalized neighborhoods. In 2021, nearly 25 years later, a similar picture of burden emerged out of the Pacific Northwest heat dome, a quarter century later. This consistency is not only where and why it is hotter in particular places, but also where people are suffering the most in our cities isn't coincidental. It's actually rooted in history. Next slide, please. In 2020, we published a paper exploring how patterns of early 20th century redlining, or kind of the racial spatial ideology that was prevalent throughout the history of urban planning and real estate in the late 1800s and early 1900s, that Black, brown, and immigrant communities were inherently of less value and thus riskier for investment than whiter and wealthier neighborhoods. We investigated how that relates to present day patterns of extreme heat and land use. And while the actual use of these Hulk maps, the one popularized by the University of Richmond, that actually guided loan approvals is somewhat argued by historians, the climate and land use patterns we identified have now been confirmed by nearly a dozen or more follow-on studies. Formerly redlined areas are hotter. Next slide, please. They are dominated by paved over surfaces. Next slide, please. And they have many fewer trees than their non-redlined neighbors. Other studies, including some of my own have further linked flooding, poorer air quality, and poorer health outcomes to these redlining maps as well, reflecting other planning decisions that happened in subsequent decades, like urban renewal and building the highway system, in exacerbating these inequities: hotter, wetter, sneezier, and wheezier. But it doesn't just stop at redline neighborhoods either. In over 70% of US counties, there is a disproportionate exposure to higher surface temperatures for poorer and communities of color. The need for shade, both nature-based and built, is absolutely clear. So next slide. The Groundwork USA Network is an affiliated network of place-based, people-centered environmental justice organizations known as Groundwork Trusts. We believe that by changing places, you change lives and change systems. And we've been doing this since the first 3 trusts were launched in 1998 through the EPA and the National Park Service. Today, there are 21 trusts across the country. We've improved over 12,000 acres of EPA-designated brownfields, planted tens of thousands of trees, impacted thousands of young people, and put into practice the voice and vision of frontline communities all over the country through our programs, which I'll highlight a couple of them now. Next slide, please. For example, in Richmond, Virginia, Groundwork RVA helped establish the now nationwide NOAA Urban Heat Island community science campaigns in 2017. We discovered a 16-degree Fahrenheit difference between the warmest and coolest place at the exact same time during a heat wave. Since then, Groundwork RVA has guided the community engagement process for the RVA Green 2050 Climate Equity Action Plan, while creating a pipeline for resources to go directly into formerly redlined and frontline neighborhoods for the city of Richmond's new parks, stormwater gardens, youth and workforce programs, and while planting hundreds of public street trees that have lowered surface temperatures on particular blocks by 20 to 30 degrees Fahrenheit during the height of the day during the summer. Next slide, please. Groundwork Hudson Valley has been partnering with residents of affordable housing complexes in Yonkers, New York, to install cool roofs, which reflect more of the incoming sunlight than typical roofs. This heat mitigation strategy has also the added benefit of reducing indoor energy consumption due to the reduced indoor heat transfer, especially for the topmost floors. Next slide, please. In keeping with previous studies, our team has estimated that these top floor apartments have seen about a 15% reduction in their monthly average energy consumption. That translates to real savings that can go to other really relevant resident needs, especially at this time of very high costs. Next slide. Lastly, I wanted to highlight the Adopt a Tree program from Groundwork Ohio River Valley, which pays residents to water trees planted in the Lower Price Hill neighborhood. As anyone who works with trees will tell you, putting them in the ground is the easy part. Keeping them watered and maintained is the real work to ensure that their shade does actually what we hope that it does. These sorts of programs that, again, are focused in frontline neighborhoods like Lower Price Hill, where trees are needed the most, not only increase the likelihood that this historic federal investment in putting trees into the ground through the USDA is successful in its aims, but it also creates a network of ambassadors, elevating the social capital of these residents and encouraging them to get more involved in stewarding the investment. That committing to building the capacity of frontline communities to take care of themselves is where these federal investments and programs like ours go the farthest in sustaining an environmentally just future. And so next slide, please. I'll close with the Groundwork USA theory of change. Changing places, changing lives, changing systems. These are the strategies that can build durable resilience to growing climate threats like extreme heat with tree equity while working to repair the harms of the past. So thank you so much for your attention and for joining us today. It's my pleasure to pass it over to Jenny Economist.
Jeannie? Did we lose connection with Jeannie? If so, we'll move on to the next group. Jeannie, are you here? Okay, looks like Jeannie lost internet service. Give us 1 second. Renee, can you move forward to the next presenter in the slide set? Okay, Dr. Gillums. Dr. Gillums?
Quick sound check. Do I sound okay?
You sound great.
Thank you. All right. Thanks a lot, everyone. My name is Sherman Gillums. In terms of my description, I'm a black male with medium brown skin, a little facial hair, and a freshly shaved head. And if you see my picture, you probably see a female background behind me. Let's go to the next slide, please. Are the buses coming in? These are the last words of Ethel Freeman, a 91-year-old retiree, a mom and grandmom who survived evacuation after her son pulled her from her home during Hurricane Katrina, and he waded his way with her on a boat to get to a dry patch of land where they were directed to a convention center. And they were told to wait outside for the buses. Now, the buses did come 4 days after Ms. Freeman asked the question, 4 days after she had died under the searing heat. Now, her image in her wheelchair, covered by a poncho, would shock the conscience of our nation and serve as a cautionary tale in disaster response. Next slide, please. Now, Ethel is the reason the Congress passed the Post-Katrina Emergency Management Reform Act and why I currently serve in the role as disability coordinator for FEMA. It wasn't the hurricane that killed her. It wasn't even the heat. In my view, it was the lack of awareness and preparedness for the slower moving existential threat to the lives of people who are predictably the most susceptible to heat injury or death in a fairly short period. Next slide. Now, Ethel died 19 years ago as disasters have become more frequent, more intense, and more costly, and they're happening in places they didn't happen before. Now, as this is occurring, people with disabilities are becoming more independent, thanks to the community living movement, which also means that people with disabilities can live in rural areas or areas without accessible transportation, provided that this independence is premised on social systems, infrastructures, and general attitudes that see them during blue skies and disasters. Next slide. Now, when disasters occur, my office uses these data sets to scale the risk. The U.S. Census, which is often aged out of utility, so we often have to rely on other lists. But we also look at the vulnerability index. We look at our own applications during disasters, but that H&H Empower list becomes critical because those are the people who rely on power to survive. These are people with dialysis. These are people who maybe rely on oxygen. And when the power goes out, they're the ones whose lives are at most risk. Now, here's the important difference, though. Extreme heat alone is not a declarable disaster. FEMA doesn't get a state doesn't get a presidential declaration when extreme heat occurs. So it's very important that we pay attention to that nuance relative to other disasters. Because heat kills more people faster and in greater numbers than even the largest, most violent weather events like tornadoes, like hurricanes. And a lot of it happens because of its illusory, slow-moving effects, a lack of preparedness, and complacency on the part of many. However, even during disasters, it's easy to underestimate extreme heat in the aftermath of, say, a hurricane relative to the initial event, because we're paying more attention to the initial event than the heat. And then you can look at studies in the aftermath of Hurricane Maria in Puerto Rico, and more recently, Hurricane Fiona, where we saw heat correlate with suicides, with mental health issues, because of the prolonged exposure to heat and deaths, especially among people who were in nursing homes and places that didn't have air conditioning. Next slide. Now, we know that disabilities come in many forms. Many are visible, and some are invisible. We can think of people who have epilepsy, and other forms of disability that don't show up immediately, or the cumulative effect of having, say, a physical and an invisible disability that may not be obvious. Now, extreme heat impacts those who cannot self-thermal regulate. I'm a person with a spinal cord injury. When I go outside, I can't sweat. I've got to pour water on my head to cool my body off, so I'm an example. But it can also happen to people who take certain medications, as well as those who can't express how they're being affected by extreme heat, such as kids with autism, certain types of autism, the nonverbal types, or older people with dementia are a couple of examples where extreme heat may be having an effect, but the person can't express what's happening. So we rely on the vigilance of caregivers and the community to augment public alerts and warnings in those cases. Next slide. Now, I took a good look at the Chicago case study, the mid-90s Chicago case study, where older people who did receive alerts. They were getting the alerts about the heat. But what superseded those alerts were local issues. And in some cases, people were dying in clusters in areas where the crime rate was pretty high. So when the power went out, people didn't open windows. They didn't open doors. They didn't seek help. They didn't answer knocks at the doors because of the crime, and the police were preoccupied with a lot of other things. And so they didn't see it as their job to check on people, again, who were dying in bunches. And so when we see that happen, what we see is not a problem with the heat, but with the system and the way it was set up to account for people, especially those who we know are more vulnerable during heat waves. And what added insult to injury in the Chicago case, besides the fact that the warnings were ineffective, was the fact that many attributed the deaths to old age and not heat, right? And so we had a real problem there, because then you diminish the danger of heat in those cases. Next slide. Now, what we do at FEMA is we aim to enhance preparedness before heat waves through engagements such as these, by encouraging communities and every level of government to confront the problem together and account for the most vulnerable communities together. In addition to campaigns such as #SummerReady, which you can find on the ready.gov website, we also offer training on our Emergency Management Institute website. We also encourage communities to develop plans that can include things like door-to-door check-ins when you know there's a heat wave. And people may not be as internet savvy. So you have these door-to-door, sort of like community vigilance or community watch strategies. But things like having the Nextdoor app activated, checking in on people, or looking for posting boards where people are talking about the heat and how they're talking about it, and other planning efforts that take into account those local challenges, which is really important. For older adults, we also have the ready.gov /older-adults. Again, ready.gov /older-adults. And we also have ready.gov /heat. Those are two examples of how we're contributing to the effort to make sure that preparedness is the first response during heat emergencies. Last slide. I'll close by saying that extreme heat is the most non-obvious yet dangerous threat we face, because we associate hot weather with beaches and cookouts and family reunions. But it's social isolation, it's a lack of information, and poor coordination that do more damage than heat alone can inflict. Last slide. If you want to reach me by email, there's my contact info. Thank you very much.
And thank you. Jeannie was able to make it back on. So Renee, if we can go back to Jeannie's slides. There we go. Very quick. Jeannie, are you here?
Yes, I am. Thank you very much. And my apologies for that. It's ironic that it should happen just right now. So thank you for this opportunity to be here. We're going to talk about farm workers today. And if you had lunch or breakfast or dinner today, then please thank a farm worker for harvesting the food that you're eating. Next slide, please. We're going to talk about farm workers in rural communities, often marginalized communities. So who are farm workers? They are the invisible people behind our food system, and they are the essential workers. In the United States, they're often people of color. Historically, it was largely African-American or Black farm workers. Today, it's largely Hispanic and Haitian in Florida, and also Asian farm workers on the West Coast. They have low wages, poverty wages. They are often victims of wage theft. They have limited formal education and often limited or no language proficiency. The major language in Florida is Spanish and Haitian Creole. They're often subject to harassment, intimidation, discrimination, and exploitation in the workplace. And there are even cases of labor trafficking that is an issue for farm workers, especially in the H-2A guest worker program. They often have lack of access to health care, and they have no workplace benefits and no health insurance. They live in very marginalized rural communities, and many of the farm workers in the United States today are undocumented. Next slide, please. So the realities of farm worker are their really adverse living and working conditions. So farm workers that are harvesting the food and doing some of the most important work in our country are exposed to heat, cold, storms, and out west, even wildfires. They're often also exposed to pesticides. There are insects, snakes, and dangerous farm equipment in the workplace. They work long days with few breaks. Farm workers tell us that they don't have a chance to stop and drink water, don't have a chance to go to the bathroom or even eat lunch. They're often paid by piece rate, which incentivizes them to work faster and longer without stopping because they're paid by how much they produce. There are often no bathrooms or drinking water in the fields, and we have lots of stories of farm workers telling us about these horrible conditions. In addition to that, they often live in substandard or inadequate housing where there might not even be any air conditioning. Their housing is often in remote rural areas where they don't have access to the services and even the information that lots of others do, including lack of transportation. There's often multiple families per household to afford cheaper rents. Sometimes they live in barracks-like conditions where there are very minimal amenities. They live in flood-prone areas, so they're subject to disasters, and they often don't have to pay someone to take them to work or to school or to medical appointments. Next slide, please. So you can see from these conditions that they're already a very marginalized population. And we heard earlier about agricultural exceptionalism. This is really important to understand because in the 1930s, when the labor laws were passed that protected almost all other classes of workers, domestic workers and farm workers were deliberately and intentionally excluded from the National Labor Relations Act, which gives workers the right to organize and collectively bargain. So farm workers do not have the right to form a union under the NLRA. There's also the Fair Labor Standards, which has a minimum wage, overtime, workers' comp, and childcare laws for all workers, but it did exclude farm workers and domestic workers. And they were also excluded from safety under the Occupational Safety and Health Administration Act, which except under the General Duty Clause. So there's no real standards in OSHA to protect all workers from heat. Next slide, please. And so the reality is farm workers in the United States today are living the legacy of slavery. The first farm workers were enslaved peoples working on plantations, and the racism, the institutional racism that is the history behind our agricultural system exists today, with most of the farm workers being from minority communities. And so environmental justice was coined in 1973 with the environmental justice movement starting then. And farm workers are an environmental justice community. They're often not seen as such. They're often not recognized as such. But in addition to heat, they're also exposed to chemical fertilizers, pesticides, dangerous farm equipment, and other factors, other risk factors. So next slide, please. And you can see the pictures here of the farm workers. There are an estimated 500,000 farm workers under the age of 17. The majority of children working in farm children working in today are working in agriculture, and it's approximately 70%. Women make up a large portion of the farm worker workforce, especially in Florida. And today, a lot of farm workers are climate refugees from Central America and the Caribbean. That includes hurricanes that hit in 2020. People are also escaping from violence and instability in their home countries. And you can see the picture of the woman on the right-hand side. She is working in a fernery. You can see that it's a very sunny conditions, but yet she has a hat on. She has long sleeve shirts. She has gloves, she has a plastic bag around her. The reason for this is the long sleeve shirt is to protect her from both the sun and from pesticide exposure. And workers have to wear these kinds of clothes and other PPE. Sometimes they wear suits, hazmat type suits when they're spraying pesticides. And it's really important because not only do they have the regular ambient heat, but then they have exertional heat from bending up and down and moving all day. And then they have the heat from the clothing and the PPE that they're wearing. Next slide, please. And so I'm going to talk a little bit of farm workers and pesticides because there's a synergy between pesticide exposure and heat. So agriculture is one of the most hazardous occupations in the United States. The death rate among farm workers, you can see here, is higher than in other occupations. And according to the EPA, there's about 90 million pounds, and I think that's even increased since then, applied to crops every year. And there's an estimated 10,000 to 20,000 acute pesticide poisonings among farm workers in the United States. That's an underestimation, just as heat stress numbers are also an underestimation. And farm workers are 39 times higher than all other workers to be exposed to pesticide poisoning, to have pesticide poisoning incidents. Next slide, please. So farm workers have multiple symptoms from pesticide exposure, including rashes, nausea, headaches, vomiting, dizziness, cramps, and there are long-term effects. But look at the symptoms of pesticide exposure. They're very similar to heat exposure. So when a healthcare provider is working with a farm worker that has symptoms, they have to identify whether those symptoms are related to heat or related to pesticide exposure or something else. One of the big problems that we see for farm workers and all outdoor workers, but especially for farm workers, is that healthcare providers often do not ask questions about a person's occupation, and they just treat the symptoms. They don't look at the cause of those symptoms. And so a lot of times cases go undiagnosed or improperly treated. And then also pesticides can have long-term effects such as Parkinson's disease, cancer, birth defects, and fertility problems. And I say this because there are some recent studies that have looked at the combination of heat and pesticides, and there needs to be more studies on this. But the studies that have been done have shown that increased high temperatures can increase the absorption of pesticides in a farm worker's body. So you have cumulative impacts here from both heat and from pesticides. And pregnant farm workers are at risk from pesticide exposure, but also it's also shown that pregnant women are more that have low birth weights and problematic pregnancies related to the heat as well. So this is a very vulnerable community, and they're often overlooked because they're rural communities and they're marginalized communities. They're people of color, even though they do some of the most important work in our country. Next slide, please. And so I wanted to just, yes, so this is a person that's applying pesticides with a hazmat suit on. And the body temperature, core body temperature rises with exertion and the outside heat temperature. And then farm workers also lose a lot of fluids and salts due to sweating, and yet they're often not given breaks. We have farm workers tell us all the time that they can't stop and drink water. Long-term effect of dehydration can lead to kidney failure and other long-term health effects. The next slide, please. So the Farm Worker Association of Florida has been working with Emory University for over 12 years doing research on farm workers and heat stress. And very quickly, from one of our first studies with Emory University, we looked at different biomarkers of farm workers on 3 consecutive days related to their work and their heat. And you can see from this diagram here that of the participants studied, there were over 200 farm workers studied in that first project. 53% of the participants were dehydrated before they even started work. 81% were dehydrated after work. You can look at the middle figure that only 10% of the people that we studied maintained a normal body temperature throughout the day. 90% exceeded 100.4 degrees Fahrenheit, which is like having a fever on at least one day. And the participants in this study swallowed a pill that monitored their temperature and their heart rate every 30 seconds throughout the day. And that's how we got these statistics. So you can see that 36% had acute kidney injury and 42% developed at least 3 symptoms or more of heat-related illnesses on at least one day. Next slide, please. These are some of the symptoms, long-term and short-term, but these are the organs that farm workers, that heat stress affects, dehydration affects the body. And one of the things that the Farm Worker Association has done as a result of these studies with Emory University, we are conducting heat stress trainings with farm workers all across the state of Florida. Of course, we're a small grassroots organization, so we can't reach all the 150,000 farm workers in Florida, but we do talk about how dehydration and heat exposure can affect all these vital organs of your body, to try and encourage farm workers, in spite of the working conditions, to try and drink water and protect themselves. Next slide, please. And so for 6 out of the past 7 years, the Farm Worker Association of Florida has tried to get the state of Florida to pass heat stress protections for farm workers. Unfortunately, all those efforts failed. At the national level, we're supporting the a heat stress bill, but in the meantime, this past year, in March, the state of Florida passed a heat preemption bill, which prohibits all local governments from enacting protections for outdoor workers, including farm workers, from any kinds of heat protections. It's a really outrageous bill. It's very cruel to workers that they cannot get protections, including it does not allow for training and even information about heat. I'm going to put a link to a news article in the chat right after this presentation, but it's really important to know that we are not stopping here. We're going to continue to do everything we can to protect farm workers from heat stress, including trainings, but also working on a national level for heat protections, and also seeing what we can do on a state level as well. Next slide, please. And I just want to say that this is a social justice issue and an environmental justice issue. So we have done heat stress trainings for farm workers in Florida. We do have educational videos that we have done for farm workers. We're also planning a big heat stress campaign for this summer to share the results of our research with Emory University, but also to inform workers about how to protect themselves, how to identify signs and symptoms, and crucially, how to work in pairs so that you can protect your co-workers, because there were 3 farm workers that died in 2023 from heat-related illness. And we don't need any more deaths of farm workers, because they're coming here to do hard work for their families and their communities. Next slide, please. I'm sorry, I'm going really fast. I just wanted to make up for time. So thank you very much. We are a statewide nonprofit organization, and we are committed to social and environmental and climate justice for our communities. I'm happy to take comments. Our website is www.floridafarmworkers.com, and please protect farm workers. Si se puede, yes, we can, and we must protect farm workers from heat. Thank you very much.
Next up is Juliana Reese. Renee, can we move to, there we go. Renee, so fast. Juliana?
Yes. Good afternoon, and thank you for inviting me to speak with you today. My name is Juliana Reese. I'm the current Director of Healthy Tribes with the CDC's National Center for Chronic Disease Prevention Health Promotion. I'm going to do a formal introduction in Navajo, as it's customary in my culture. For this talk, I'll do a brief overview of some key considerations for addressing heat health in American Indian and Alaska Native populations. I want to first say that not all of what I say can be generalized to every tribe or every community, nor do I speak for all tribes. I draw my words today from my experiences in medicine, public health, science, education, and life. My intent is to shed light on some important considerations specific to American Indian and Alaska Native populations. Next slide, please. We've heard quite a bit already about how extreme heat impacts certain populations more than others. We know American Indian and Alaska Native populations are disproportionately affected. We know racial, systemic, and institutional inequities exacerbate and perpetuate heat-related concerns. Social vulnerability in urban settings and rural or remote locations also exacerbate these impacts. Social determinants of health, and specifically indigenous determinants of health, which you'll hear a bit about today, lead to increased health disparities, which in turn increase risks of heat-related illness. We also know that extreme heat events are projected to increase in frequency and intensity with continued climate change. In tribal communities, they have distinct characteristics and history that exacerbate risks for health disparities and increase the risk for heat-related illness. This information is critical to understand when working with American Indian and Alaska Native populations. Next slide, please. Currently, there are 574 federally recognized tribes in the United States with immense diversity in geographic location, language, customs, dress, government systems, and belief systems. There are clearly far more than 575 tribes in existence, but only the federally recognized tribes are eligible for federal services, programs, and funding allocated through the federal government in response to the federal Indian trust relationship that has been established. Although the federal government determines which tribes are recognized, the tribes themselves determine their membership. The diversity of tribes goes far beyond just population, location, cultural differences. Each tribe has a different relationship with the government entities like states, counties, and other territories. This relationship impacts all part of healthcare for tribal communities, particularly funding, service, response, coverage of in-house or referred services, data sharing, and much, much more. Data for American Indian and Alaska Native populations is wrought with inaccuracies due to many aspects, most notably misclassification and misidentification. We heard a bit about this in an earlier presentation regarding the National Death Index. This topic is much too big to go into right now, however. Lastly, the public health capacity, workforce, and infrastructure ranges from minimal to extensive depending on the tribal community you are focusing on. Next slide, please. The concept of tribal sovereignty is complex, but critical to at least have a basic understanding of. Sovereignty means the tribes have the inherent right to govern themselves as sovereign nations. Since the formation of the Union, the United States government has recognized tribes as sovereign nations. This resulted in the transfer of land under treaties and the institution of federal programs and services such as healthcare. This unique United States federal tribal relationship is a formal government-to-government obligation, a trust responsibility, and applies to all the work we do in the federal space. If you take one thing away from this talk, please understand that the relationship between tribes and the federal government is political and legal, not race-based, like with other racial and ethnic groups. This is truly what makes work in tribal communities unique, and it is our federal responsibility to respect and understand sovereignty. Next slide, please. Native populations have suffered immense trauma from colonization, loss of traditional lands, indigenous foods, and cultural practices, including language, traditional family and parenting structures, and traditional ways of life. It's important to understand these historical and present factors and how they contribute to the staggering health disparities we see today in American Indian and Alaska Native communities. In this talk, I'll touch on climate change and the environmental impacts that compound the trauma in American Indian and Alaska Native communities. The EPA put out a great resource that will be included in the references that outlines this very well. Next slide, please. Speaking of disparities, this slide shows just a couple current statistics in American Indian and Alaska Native populations. In general, you can pick a health disparity, and the likelihood that American Indian and Alaska Natives will have the worst statistics proportionately is quite high across the board. And now you may know just a bit more about why this is the case. Each of these issues impact heat-related morbidity and mortality. For all other racial and ethnic populations, life expectancy has done nothing but increase in the United States. For American Indian and Alaska Native populations, life expectancy at birth is 10.9 years less than that of all U.S. races. In fact, in 2021, the life expectancy for American Indian and Alaska Natives dropped to 65.2. This represents the greatest decline among all races from 2020. American Indians and Alaska Natives have the highest poverty rate of any racial and ethnic group at 24.3% versus 11.6% overall. We all hear about high rates of alcohol use and substance use disorder, but we rarely hear positive statistics like American Indians and the populations in American Indian communities that have some of the highest rates of alcohol abstinence. There are also high rates of chronic diseases such as heart disease, diabetes, liver, and kidney disease. And we've heard statistics on how these exacerbate and perpetuate heat-related risks. Tying all these health disparities to heat-related illness, between 2004 and 2018, the CDC found Indigenous populations to have the highest rates of heat-related death than any other population. Next slide, please. You've heard the risk factors for heat-related illness, but I'll speak to some more specific risk factors to tribal communities. Outdoor time. Many American Indian Alaska Native individuals work in outdoor jobs such as construction, farming, ranching. In fact, American Indians and Alaska Natives make up a large proportion of military personnel who are often placed in extreme heat situations. Recreation and sports facility areas are largely located outdoors, and so much of the time that children spend and adults is outside and not within the household. Those without transportation tend to also spend more time outdoors, walking or hitching rides. Many American Indians, Alaska Natives cannot spend time indoors due to lack of housing, multi-generational homes, and cooling costs. Lack of housing in tribal communities has made multi-generational homes the norm. There are significant obstacles to obtaining land and homes in tribal communities, leaving many homeless or living with others. Many live out of their cars, and in many cases, cars are more important than a home to be able to maintain and commute long distances for employment, medical care, and supplies. Many tribal communities lack infrastructure to provide basic necessities such as clean water, plumbing, electricity, cell service, and broadband, making implementation of action plans that have been created for other communities quite impossible and unrealistic in tribal communities. For reservation lands, many are located in rural and remote areas, often quite isolated and situated great distances from one another and from urban areas, making it more difficult to provide cooling areas or utilize common action plans that suggest this. The urban heat island effect is a very real phenomenon for American Indian Alaska Native populations, particularly for the urban Indian populations. An estimated 75 to 80% of tribal members reside off reservation lands in urban areas, largely for employment and education purposes. Lastly, the air quality can be of great concern due to wildfires and the frequent sighting of polluting industries on or near tribal populations, increasing particulate matter, ground level ozone, which compound the risks. Next slide, please. Many American Indian and Alaska Native individuals and communities engage in traditional and cultural practices and use traditional herbs, which have been vital to the health and wellness of our populations. It's important to provide culturally appropriate information about how extreme heat can complicate processes, emphasizing preparedness of daily living, including traditional practices and herbs to ensure safety rather than discouraging traditional practices or traditional medicine. Information must be relevant regarding the mitigation of heat-related risks, the use and storage of medications, particularly in cars, and the risks of chronic diseases and signs and symptoms of dehydration, heat exhaustion, heat stroke, etc. It's important to support the wellness efforts while respecting Indigenous ecological knowledge and traditional ways of knowing. Next slide, please. It's important to understand the unique dynamics of American Indian and Alaska Native communities that make heat-related issues distinct. Historical trauma impacts, social determinants, specifically Indigenous determinants of health, the federal trust responsibility and what that means in your federal employment role, diversity of tribes, villages, and urban Indian organizations, the complexities of federal, state, and county relationships and how these impact access to funding, data, and healthcare in general, geographic and infrastructure challenges, and of course, cultural considerations. It is also critical to engage, listen, and partner with tribal communities early and often. To use culturally appropriate approaches that are strength-based, community-led, and avoid a paternalistic, deficit-based approach that disregards traditional ecological knowledge and community input. To support community-led solutions for climate change action plans that are focused on energy strategies, flexible funding, protection of water on tribal lands, infrastructure, and capacity building, and to ensure traditional knowledge is considered, supported, and integrated into environmental policies and decision-making at the forefront. Next slide, please. I've included some references here if you're interested. I think these slides will be available, but I want to say thank you for inviting me to speak. And I think I will pass it on now to our next speaker, who will open it up for questions and answers.
Next slide, please. A window. The first question we're going to go to will be answered by Jeffrey Hall. The question is, how do you deal with common shelter issues such as substance use, gender-based violence, and similar in cooling centers?
Okay, thank you for that particular question. I do think that the way that you would have to approach that particular question has to be viewed in terms of the characteristics of the specific populations that you're having to deal with in the locations that are of interest. My philosophy about solutions to deal with issues such as the ones that are described are always very much mapped on top of both context as well as some of the population related characteristics. So to be able to give the fullest answer, I would actually need to have a little bit more of a thorough conversation to be able to really drill down into an answer that might be more satisfactory for the person that has posed that question. I'd be happy to do so offline if there would be interest in doing so.
If you want to follow up, you can email us at ehnexus@cdc.gov and tell us whom you wish to reach, and we'll pass your request on to the specific speaker. Okay, so the next two questions actually are going to be for David. David, are you available?
Hey, Jonathan, yes.
Okay, so well, first, what is a respite center?
Yeah, thanks for the question. Similar to what we heard from Jeffrey Hall, we would encourage jurisdictions around the country to develop and adopt terminology for the different types of heat relief facilities that work for them. We realized in the past couple of years that we had facilities that were operating very differently. Some that had a few chairs in an air-conditioned lobby where you could come in and hang out for a few minutes, and then it wasn't really an ideal spot to stay for very long, and others where there are yoga mats on the floor and sleeping is permitted and so on. And we didn't have good vocabulary around that. So we weren't necessarily helping guide people to the places that could most effectively meet their needs. So we adopted the term respite center as the type of facility in our heat relief network that where prolonged rest is permitted.
Thank you. And then the next question, have health departments used these cooling centers as places that provide an opportunity to reach out to people who may be experiencing homelessness or have a substance use issue, an opportunity to test for HIV or other STIs, and an opportunity to give out resources?
We are certainly trying to do that with our added efforts this year here in Phoenix. We are having some health providers who have mobile vans and trailers rotating through these facilities on a weekly basis. We have nursing students who are completing rotations, helping out at these locations, providing services as well. And just reiterating a theme from the presentation, professional navigators, case managers, social workers at these facilities, we're really trying to flood them with resources to ensure that they are much more than just a cool space where we can and where that makes sense. So thank you for the questions.
Okay, thank you. The next question is open to any of our speakers who want to answer. It is an interesting discussion as well. They're asking, does using a library as a cooling center interfere with the function of the library? And I suppose you could ask that question about any public facility. David, you turned your camera on. Looks like you would like to take that question.
I will just, thus far, we've been able to do so in a way that does not introduce that conflict, but we've had to think about it a lot. And that conflict could be physical conflict on use of space. it could be perceived conflict of who's in the library and why are they there. There's a staffing conflict in that the same people who are staffing the libraries or doing other missions are now being asked to do more. So we've been that deconfliction exercise has really been top of mind for us, and somewhat to our surprise, was also of great concern to a lot of our community members this year. So we've had good conversations with neighborhood groups and others. I know we have other people who might answer. We were very fortunate for our primary space for this mission this summer to take advantage of some underutilized space in one of our libraries. But this is a real concern that I would strongly encourage other communities around the country to work through as early and thoroughly as possible.
Okay, thank you. Well, and that would appear to be all of our questions, and it's perfect timing. We've just run out of time. So thank you everyone for being here. Next slide, please, Renee, as well. Thank you everyone for being here so much. If you have any follow-up questions, please send them to ehnexus@cdc.gov and we will pass them on to the appropriate people. And thank you so much to our presenters as well. Everyone, I hope you have a good evening.